I was asked to talk to you guys not so much about the technical aspects, not so much about what you already know. So I understand that BTL has hosted seminars on the radial shockwave in the past here and there with regards to technology, with regards to the research and the evidence-based practices and the literature and all that. So I was asked to say something else, something that you can't really find in the books, and to talk to you about my personal experience with the equipment. I'm gonna start from years ago when when we when I started in physiotherapy. As probably most new graduates, I didn't have any financial opportunities, so obviously to afford any kind of technology was very difficult at the beginning. And like anybody else in the early years, you get to rely on your hands and on your knowledge, on your exercise prescription, on your manual therapy skills. And that's how I started back in the same year of my graduation. When when I graduated a few months later, I decided to open a little practice, which was like just one room with one bed, one chair, one desk, and all I had is my two hands. So I was eager to work and help people, and things were going well for me from the get-go. The only extra skill I had on top of the physiotherapy back then was acupuncture. So between the acupuncture needles and my hands-on experience and exercise, I managed to create a good clientele and get some good success. I had a lot of referrals, word of mouth referrals. Things were going well. For me, I worked in the local hospital as well for 6 years before that's happened in Bulgaria, before we actually immigrated to Canada. So we came to this new country here with the new opportunities. The system in Canada, as I mentioned, is very, very different from what we do in Europe. Took us, when I say us, my wife is also a physiotherapist, so that's why sometimes I tend to speak in plural. So the two of us started working for local clinics and employers, and took us about 6 years to truly understand the system, and to decide to eventually open up our own practice. That was one of our dreams in the new country, to eventually be able to offer some sort of a different approach, some sort of a combination between what we've learned in Europe and what we've learned in North America. Anyway, 6 years later, in 2007 it was, we did open a Balanced Body Health Services, is the name of the facility, the clinic that we own. And again, that was another fresh start, another beginning. Shortage of funds as always, so again relying a lot on your experience and hands-on therapies. At this point, we managed to afford like a basic ultrasound system and electrical stimulation machine. So with 2 machines and a spinal decompression system, we opened up a brand new clinic in a fairly, well, I would say mid-size or maybe even small town. I mean, the population here is less than 500,000 people, and there is a lot of physiotherapy clinics, so a lot of competition. Anyways, we managed to, over the years, to prove ourselves on the market and to turn that business into profitable organization, and that allowed us to slowly started thinking of investing into modalities. In fact, there is an interesting story because before that happened, before we actually managed to afford modalities, um, there was that person, which I'm very thankful to, who happened to he had this Shockwave machine in Canada, just one machine in Canada, and he had it at a clinic in the capital in Ottawa for a trial. So nobody knew much about shockwave therapy back then, 10, 12 years ago, especially in Canada. So that clinic tried the equipment, and they didn't want to keep it. They didn't have a success. Maybe they didn't know what to do with it anyway. So Jan was moving to the States, so he asked me, "Can I leave that equipment with you for a trial?" And I said, "Not really. Firstly, it's an expensive machine. Secondly, I also didn't know what to do with it, and what can I expect from it. You do some reading here and there, but again, me knowing how much I can achieve with what I had already, I thought I can do it all. And it turns out it's not quite the case. Like, I mean, you can be really good with your hands, you can be really good with your other skills as a therapist. And turns out later on, and I'll get back to that in a bit, that the Shockwave has the ability to do things that you cannot do with your hands, you cannot do with your acupuncture needles or exercise, specifically when it comes, for example, to calcium deposits removal. We started to see results that we have not ever been able to achieve with any other means. So I understand some of you guys that are attending, maybe you do have the equipment already, but some don't. Maybe you're just thinking whether to purchase one or not. My answer is obviously for at this point will be yes. Every clinic needs to have a modality that can do what the Shockwave can do, but I will try in my conversation today to tell you why. It's not just that as simple as like, yeah, you need it, get it. You need to know why and what to do with it. So what the Shockwave's given us is a few very important things. One of them is again the mobility, the ability to treat conditions like the calcium deposits, heel spurs, old scar tissue with it in a very, very short times, very few sessions, and also treatment times with the Shockwave units are quite short in a way that there is treatments that are maybe just 5 minutes, and maybe the longest treatment can be 15-20 minutes. So that's a time saver on one hand. At the same time, it is quite deep and aggressive technique that allows you in a very short time to achieve significant results, significant tissue response, and benefits in order to optimize the results of your treatment session. So that's one thing that the Shockwave allows you to do, is to treat things that there is not almost no other ways to achieve. Another thing, it's revenue builder with a high technology like this and short treatment times. We are able to charge significant fees for the therapy based on effectiveness, based on saving time and achieving results, saving people from surgeries in some cases. We often introduce the modality to our patients as a last resort, especially when our patient has been referred to us by the surgeon, where the surgeon is already suggesting either cortisone therapy injections or surgical intervention. And that brings me into the other advantage of this machine is that, as you know, physicians and doctors, they're familiar with the technology, since the shockwave therapy is a known way to remove kidney stones. Doctors do trust that technology. They understand it, and therefore they refer patients for therapy specifically with shockwave. So in my experience in Canada, before the shockwaves, all the doctors' referrals for to a physiotherapist used to sound like um, the diagnosis and then assess and treat. So the um, recommendation, the referral letter used to be more generalized to the physiotherapist to assess and treat, but how, they had no idea, or they may have some idea, but they wouldn't specify what approach we take. Since the shockwaves that have changed, we get referrals where the doctor would specifically write shockwave therapy at 6 sessions once per week. So quite detailed prescription. So that really increased the referral basis, the numbers of referrals to physiotherapy, because doctors were again, they're familiar with the technology, they trust this technology, they know the job would be done. So that's also a revenue builder right there. And the reason I'm saying that again is in Canada, I do go to different seminars where we talk to therapists. Some of them had the shockwave, some of them didn't. But those people who had the shockwave already, we have a therapists that were somewhat happy with the results, and we had others that were saying, we have scared away patients because it's a painful modality. At times, it's hard for the patient to tolerate. Others were saying they never got any good results. People don't come back after the first session. They keep the machine in the corner and it collects dust, and they don't know what to do with it because, again, people find it painful, and they do not see significant results. So I'm going to go back 10 years ago when I was in the same situation. And why? Because like everybody else who has a new toy, a new modality, I was simply once I have the diagnosis, or I understand the condition that I'm treating, I was looking at the screen of the machine trying to find the protocol that is suggested, push the button, and treat the patient one after the other with the same protocol, because it kind of makes sense that there is some research behind it, and then um, and make people better. But I run into the same issue. So what was happening is often people would be in so much pain, especially if you treat a bony prominence. And either they would stop in the middle of the treatment, they would ask you to discontinue that approach, or they would never come back for their second session, or if they decided to come for 2 or 3 sessions and they didn't see enough relief, they would give up on that idea. So I was getting into the same situation where the treatment wasn't as effective as I expected. And instead of giving up, I decided to try to experiment with the machine in a way that I started using it in manual mode. And why I did that, because I realized, and it's obvious, and I'm sure you've all been in that position where you realize patients don't have the same pain threshold. All of our patients, doesn't matter how they look, like somebody may look like a strong macho man, and another person may be a very fragile, tiny person, the one may have high pain threshold and the other one just quite the opposite. So you cannot really tell just by the appearance of the patient if what their pain threshold is. And since this modality, unlike other modalities, unlike laser machines or ultrasounds or electrical currents, it's in no way it's pleasant. In most cases, it's not pleasant, you know. And often it causes at least discomfort, significant discomfort, if not pain. It's very hard on the first day on a new patient. It's very hard for us to understand or to judge them where their pain threshold would be to that specific agent, to an acoustic wave, right? So it's really hard to know that. So what I ended up doing is I stopped using the protocols, and I decided that I would start with every next new patient on very minimal settings. So these machines allow you to change the intensity from 1.5 up to 4 or 5 bar. And for those who don't know what that is, it's because the machine is air compressor, the intensity is measured in bars, and the higher the number, the stronger that pulsation is, the stronger the hit is. So obviously on maximum intensity, the machine will be pounding pretty strongly and it will cause a lot of pain. And on a minimum intensity, the expectation is that it will be as gentle as it can be. So what really happened in my practice, instead of giving up on the equipment like some therapists did at the beginning, I started experimenting, and I would set my machine to minimum intensity manually for every new patient for their first visit, not for the whole visit, but the first interaction with the equipment. So firstly, what that helped me to understand, what that helped me introduce the new modality to the new patient. They don't know each other, so the patient doesn't know what to expect, and I don't know what to expect. So for me to explain how that feels, it's impossible to tell them how an acoustic wave feels on their body unless you kind of start the machine and show them. So I decided to introduce the machine to the patient with minimum intensity for a very small number of shocks, which eventually we ended up calling that one round of therapy. So in my clinic here, when we have a new patient, once we identify the source of their complaint, so that's another very important thing, but as therapists, you should always try to find the source of their complaint, not just treat their pinky because they have pain here, but think what's causing that pain. Is there a proximal and once you do your assessment, your job as a therapist, and you find out the exact area that's creating those symptoms, that's your targeted area. So once you have a targeted area, as you know, the applicator is quite small in size, so you need to be pretty specific with the application of the therapy. So once you have targeted area, you determine that your patient is suitable for shockwave therapy. And the reason I'm saying that is because, as you know, we do not treat acute inflammatory conditions, for example. So you need to also consider your contraindications. So you rule out a few things, and then once you're certain that yes, this is the modality of choice. Again, the reason I'm saying that, it's not a magic wand. You cannot just apply it on everybody for everything. As therapists, our job, first of all, is to assess the condition, understand the source and the targeted area, and then rule out all the contraindications. And once you know that this is the only or the best in patient's best favor to use this machine, then you suggest it. And once the patient agrees, then you can deliver the therapy. Again, so I'm going to talk about that little manual setup. We created a little formula here so that it's not just a random application of the shockwave. It is a formula that makes sense, and you can kind of repeat over and over again. The main idea is to comfort the patient into the treatment, to introduce the modality to that patient, and to explore their pain threshold on the very first visit, especially on the first visit. So as I mentioned, the whole idea is to deliver a small round of therapy, which again often it's just 500 shocks, based on the frequency of the machine. That can be anything like maybe 10 to 20 seconds of application. And after those 500 shocks, the machine, or you pause, or the machine will stop on its own after 500 shocks if you set it properly. And at that point, you as a therapist will have to talk with the patient and see how they feel about the treatment. So after that very short application at minimum intensity, which is just 1.5 bar, there is a pause. And what we do, we do three things, in fact, in that pause. So we ask the patient how they feel about this treatment. Often maybe ask them on the visual analog scale how they think of this treatment, of this intensity of the machine for pain levels, and so that would give you some feedback as to how they like it or dislike it. The second thing we do, obviously, is immediate observation. Once I remove the gun from the treated area, you just have a look and make sure that there is no signs of skin damage. For example, when you do work over a superficial bone, there is a chance in some patients with certain conditions that you may see some signs of skin damage. So second step is observation, just making sure that nothing's being damaged, first of all, and maybe looking for some tissue response such as hyperemia. And the third step with that little conversation with the patient is to ask them if they're comfortable if you made the machine a little bit more intense, if you increase the intensity a little bit. And when I say a little bit, that's usually a very specific number. It's 0.5 bar of incremental increase. So over the course of one single session, the whole idea is to deliver 500 shocks at a time, with pause in between each round of therapy. In that pause, you do your questioning of the patient, observation, and consent for increase in intensity. Why do we try to increase the intensity? So this is a sort of a progression of your therapy within one single session. At the end of the day, you want that patient to leave your clinic with some reaction, with some tissue response, with some benefit. Now, as we mentioned, we don't know their pain threshold. We don't know how quickly they would you'd see tissue response on one and the same condition. In different people, you may see tissue response within maybe 2,000 shocks, and for somebody else, it may take 4,000 shocks before you see tissue response. Maybe some of you would ask me, what is a tissue response? So the most obvious thing, just simply with observation, would be if you start seeing skin reaction in like a hyperemia. So if you do see the skin getting redness or hyperemia in the area you're treating, that's one way. That's a tissue response. Another one would be if during your initial assessment you had some palpable what we call knots or tight spots or trigger points. So you had a finding during your initial assessment that was palpable. Now, after each round, maybe you put your hand there and you search for the same findings. So once you palpate and there is difference, that's a tissue response. So something changed. If something changed there, that's a tissue response. Another very significant tissue response is we call it a comparable sign. So during your initial assessment, you probably do a lot of special orthopedic tests. For example, Mills, Cousins, or empty can, or Obers in the hip area, whatever, doesn't matter, whatever special test you had positive at the beginning of your treatment. After a while, after maybe every round, or maybe after a few rounds, you may decide to pause your therapy and redo that special test. And if there is a change in that finding, that's a reaction, that's a tissue response, that is that's what we're after. We're trying to cause some change in the tissue. So any of this, when any of this happens, I usually consider my session complete. There is no magic number of shocks that you can deliver to the patient, and there is no magic number. You cannot just say, and that's why I'm not so keen on using the protocols, because they're pretty specific numbers, which again, for some people might be enough. For others, maybe over treating them. For some others, it will be under treating them. So there is no way that I push one button here and I treat every single lateral epicondylitis on athletic, strong young person and my grandma with osteoporosis and give them the exact same treatment. I would never do that as a therapist. It just doesn't make sense to me. So that's why we developed that manual setup, that little, and that's what brought the success using the Shockwave technology, is just that every single time, every single patient, every single treatment is very individual, and it varies in the number of shocks. It varies in how high we made it in on the intensity side. You may be noticing I'm not speaking much about the frequency of the machine, and the reason being is, although it has its effect, the effects are very minimal for the therapy outcomes at the end of the day. So what I care as a therapist is, at the end of the day, when my patient leaves the clinic, that they feel better. With regards to the frequency, yes, the literature says that maybe it affects the depth of penetration. Well, I'm sure it does, but it's so minimal. You can imagine a machine that allows you to change frequency between 1 and 15 hertz, or the top model goes up to 20, I believe. 1 to 20 hertz is such a small range compared to what we have in the ultrasound machines, right? The ultrasound machines, we have a 1 million versus 3 million. So you change it from 1 million to 3 million, you get change in depth of penetration by, say, 2-3 centimeters. But that's the million. So when I speak frequency change from 1 to 15 hertz instead of the millions, obviously the effect on depth will be so minute, so minimal, that it's, from practical point of view, it doesn't make sense to me to even think of it. Some other literature also speaks about how the different frequencies affect the cavitation, the amount of cavitation. I'm sure that's true, but also at the same point, that effect in the cavitation is much more pronounced from my intensity levels and how many shocks I deliver. So the way I look on frequencies is pretty much how, the only thing that I really see the frequency really does in real time is how fast I'm going to deliver my shocks, honestly, which is not a significant parameter to me. That makes it insignificant, because the only thing that really changes is how fast the machine will work. If I'm delivering 1,000 shocks to someone and I use 15 hertz, obviously it will be 3 times faster than if I used 5 hertz. That's the only thing I see. So because of it, in our clinic, we use the frequency as a constant parameter, usually at 11 or 12 hertz. You probably know that the highest hertz is not recommended, especially on higher bars and higher outputs. The only time we play with the frequency, and it's for mostly for comfort of the patient, is if my patient from the very first round of therapy, my very first application, if they didn't like the idea of the whole treatment. Sometimes it's psychological. The machine makes some significant noise. On higher frequencies, it sounds pretty, like scary. Sometimes it's related to the pain level. So the only time I really change frequencies on this machine is if the patient showed immediate tolerance. So I may reach to the frequency button and try to turn it up or down. I know the literature suggests that higher frequencies are better tolerated. I've had the opposite experience with some of my patients. So to me, is the number is not so important. It's not so important if I'm going to make it faster or slower. For me, it's important that to find a number where the patient says, "Oh, okay, that I can do," and that's often the lower frequencies. The moment the machine starts working a bit slower, maybe from 11, I went down to 8 hertz. People, they feel a little bit better. Sorry about that. They feel a bit better, and I can continue my therapy. So I'm gonna go back to, let me just see what time it is. I'm gonna go back to what I specifically do. Again, don't look for evidence-based or any stats or any research behind this. It's something that I had to do in order to make the machine work, and it did. So if you wish, feel free to experiment with that little formula I'm going to give you right now. I already said half of it, but I just have to start from scratch, because during the assessment, what's very important is to separate your patients in 3 groups based on the tissue you're targeting. And the reason being is because obviously for a small and superficial area, especially bony area, you may need way shorter session as a whole, way less shocks and less intensity as a whole, versus if you're treating a large, like say ITB or quadriceps, or like some larger area or deeper area, you may need way more shocks to achieve the same or some results. Anyway, so during my assessment, I try to split patients in my mind in three groups. First group is every time I feel I'm going to be touching a bony prominence. So every time, regardless of where in the body, whether it's the AC joint, somewhere in the ankle area, knee area, doesn't matter. If I feel I'm going to touch bone. Also in this group, I put all the calcium deposits and the small and superficial tendons. So if the tendon is superficial, palpable, to me, that's all group 1. Group 2, I keep for a first layer small in size muscle groups, like your wrist extensors, maybe a portion of your upper trap if it's not the whole thing, if it's just a small portion. So small and superficial muscles. In the last group, I put all the large muscle groups and deep muscles like piriformis, or for paraspinals, if I'm going to treat a good chunk of like a larger area of the paraspinals. If I'm going to treat the whole quadriceps, that will be group 3. But if it's just the medial head, maybe group 2. So there is no strict line. But in my head, the reason I'm doing that is because each of those groups is going to take different total number of shocks. And in general, although I told you there is no magic number, for group 1, I'm trying to give patients minimum 2,000 shocks up to 4,000. So it's a range between 2,000 and 4,000 based on their tolerance, based on how quickly I will achieve some tissue response, whether it's redness, as we spoke, hyperemia, whether it's change in the comparable sign. So it's between 2,000 and 4,000 shocks for the first group. Second group is 4,000 to 6,000 shocks it takes me before I can achieve some results. And the last group takes the most because it's large muscles, 6,000 to 8,000 shocks as a total. So that's my most important criteria, is to give people enough shocks. So I don't even call my session complete before I achieved at least my minimum target. So for group 1, that would be 2,000. So I try to give them minimum that. Again, there is occasions where a bit less than that would suffice, But in most cases, you need minimum that or a little bit more. And back to those rounds of therapy we spoke, we don't give them those big numbers that I just mentioned. We don't do it at once. We split them in little rounds. So when the patient is group 1, I always have my area here on the machine, the number of shocks set at 500. That's one round of therapy. So each 500 shocks I stop, I do patient feedback, observation, and consent to increase the intensity. The only difference with group number 2 is that instead of 500, we put in the middle window 1000 shocks. So it's a little bit longer rounds of therapy. In the last group, I usually put 2000 for each round. So imagine if you treat the whole length of ITB from the greater trochanter down to the knee joint. It is a pretty lengthy chunk of muscle there. So to get any benefit, to get any reaction, you need much more impulses than compared to a little bony area, right? So so 3 groups of patients based on the structure you're targeting. First group takes total of 2,000 to 4,000. Second group 4,000 to 6,000. Last group 6,000 to 8,000 as a total. First group we give them 500 shocks per round at a time. Second group we give them 1,000 per round, and the last group is 2,000 per round. So another thing that's common in all the groups, it would be the frequency. In most cases, that whole treatment goes on either 11 or 12 hertz around there. It's not a major parameter. So pick a number and the frequency that you like and just use it as a constant. It helps with the paper. In Canada, paperwork is very important too. So especially if you have to delegate the therapy to another therapist, there's got to be consistency. So it makes our life a bit easier with describing the therapy. And the most significant parameter that we're changing during the therapy is the intensity. As I mentioned, regardless of what group the patient is in, their first round will be always at, well, on a new patient. That changes later on once you get to know your patient. But on a first-time patient, when you don't know their pain tolerance, you're going to use 1.5 bar for pressure for the first round. Now, everything after that depends on how they respond to you. So when you take the little break and you ask them how they feel about it, and if you can increase it, if they say, yes, we feel good about it, you increase it by 0.5 incrementally. So my second round of therapy will be delivered at 2 bar. And then I take another break, patient feedback, observation, consent for increase. If they say yes, another 0.5. Let's take an example of group 1 patient. So a new patient came to you and they have chronic lateral epicondylosis. Chronic, remember, we do not treat acute inflammatory conditions. So say they had this condition for over 3 months, a year or 2 years, and they've tried everything else, and now the doctor's recommending cortisons. They don't want to do that because of the side effects. So they come to you, or they were recommended to you, or you recommend the Shockwave as a modality that would turn that chronic condition into maybe more acute or heal it right away. So you recommend Shockwave. That in your head immediately is group 1 patient. It's a bony prominence. So you know you're going to set your machine on this 1.5 for intensity. You're going to keep the frequency at 11 or 12, whatever the number you picked. And you're going to enter in the middle window for number of shocks, just 500. So you're going to push the trigger, give them 1 round of therapy, and if they gave you the thumbs up, if they were comfortable with that, you're going to push the button here twice, do another 500 shocks at 2 bar now. And if that happened again and again, and once you reach your 2000 shocks, if you remember, I told you the group 1 patient would take at least 2000, maybe up to 4000 shocks before you see some good tissue response. So if you did already 4 rounds of 500 and you kept increasing incrementally the intensity and people are feeling good about it, now it's time to maybe pause and do some testing beyond the observation, see if anything changed from your initial findings. And if it did, that's all you need to do. You can stop at 2000 shocks as a total and tell them that session is complete. It's a probably 5, 6, 7 minute session. In Canada, we charge $100 per body area, so that's good amount. That's good fee for a 5, 6. Well, your first session includes more than that. Your first session, you're gonna educate, you're gonna teach them home exercise program, you name it. But on your second session, all you do might be just that, if there is no need for any hands-on. And in many conditions, there isn't. Anyway, so to stay away from that part, what happens if your patient, after 3 rounds of therapy at 1,500 shocks, they said, ouch, that really, really hurt me. And you check your comparable signs, no change yet. You want to give them at least another round or two of therapy, so you can actually achieve something, or so you can see some hyperemia, so you can see some change in the tissue. Well, instead of increasing the intensity, the only thing you can do is go down by 0.5. So pretty much go on the previous level where they did feel comfortable, and give them 1 or 2 more rounds of that until you do see some changes. And people are pretty happy with that. So once I reach my 2,000 total shocks on a group 1 patient, I'm thinking to stop the treatment around there, especially if they have had some discomfort. On the other hand, people that show good tolerance, it's not wrong on the first session, it's not wrong to keep pushing it and keep increasing the intensity. And even though it's a superficial area, if they had a good tolerance, I want them, when they leave my clinic, to say, oh yeah, this guy did something to me. He actually did something. I feel like the therapy worked. So I don't hesitate, even on a first patient, on a first time patient, providing their health history is all right. So they don't have any conditions, they're not on blood thinners. They don't have osteoporosis. I mean, we're talking about a, let's say, athletic, healthy person. I wouldn't hesitate on that person to push it, give them 4,000 shocks total, and go even up to 4 bar. But my goal here is, again, to cause some response, cause some reaction. Usually my next session is in a week, so there is time for recovery in between. Often next day they do feel a little bit sore, like bruised. I do give them a warning for the worst case scenario. I tell them, you may bruise, you may feel sore for up to 1 week sometimes. Another thing I do, because these are chronic patients, I don't advise them on taking it easy. I actually do the opposite. I ask them to feel free and to use the body part within their limits, but instead of putting them in a sling again, I ask them to get in the gym and mobilize it and move it and use it within their pain limits again, obviously. And that's how it goes for group 1 patient. The other 2 groups are the same thing. It's just like each round is a bit longer. Another thing here is important, because you probably know that the higher intensity means better penetration, more depth of penetration. Unlike the ultrasound machines, where frequency is used to change depth of penetration, on the Shockwave, the stronger your bar, the deeper it goes. So when you do treat a deeper structure, you will try to get into the higher numbers for sure. But even when you treat superficial, it's not wrong to reach higher intensities, not because you need that, but because sometimes you need to create a tissue response. And in some people, it's not so easy as in others. You'll see some people after the first round, you see that hyperemia, especially on an area where there's more musculature and better vascularization. You'll see some immediate hyperemia. And in others, you may not see this until like you're at your last round, at the end of your treatment. You don't see all that hyperemia. So pretty much what I'm trying to say here is people are different. They respond differently to the agent, to the physical agent. We don't know this on first visit. And to me, the only way to make this machine work properly for you is to use manual settings and gradually increase the intensities. As I mentioned, on a second or third visit or fourth visit, once you get to know your patient, once you know how they react, especially the next day, how they feel, if they come to you black and blue, like bruised, or not so much at all, if they had an after pain for up to a week or maybe just for a day, based on all that, once you get to know your patient, you don't need to start from 1.5 bar anymore, especially on those who managed on the first session to reach the highest intensities. I would consecutively, I would start them on a higher number. My first round would be on 2.5 or 3 bar. because patient would actually ask you, don't use those small settings there because I didn't even feel it. And once you get to know your patient, you can start. I always start a bit higher on those who did well, but I wouldn't. I would still use a little bit of that little incremental increase. I wouldn't just put the machine on max and just give them as many shocks as I can. I just see because the reason being is your first round on a lower setting allows for creation of a little bit of anesthesia. So the machine, the shock waves help achieve a little bit of a numbness in the area, a little bit of a change of a sensation, which is why we're able, when we do this little incremental increase, we're able to start from a very little intensity, and then in some cases within the same session reach the max intensity, and the patient is still comfortable because of that almost immediate analgesia. And that's the reason that I'm not super excited when sometimes at the end of the session they tell me, I feel so much better, pain is gone. So I usually tell them, well, that's good, but let's see how you feel tomorrow, because then the anesthesia will be gone, and then they will feel all the bruising, or the effect of that metal and those acoustic waves had on the tissue. So they feel, often they feel a little bit worse next day, 2-3 days after, and in the worst cases a full week after, they still feel, or even visibly they look bruised, especially if you worked on the calcium here and you had to put pressure, physical pressure. And in those cases, I advise them to take another week before I continue with the therapy. I don't want to apply another shockwave session on an area that's still not recovered from the first one. So sometimes the distance between sessions is a bit larger on the patients that do bruise easily. Instead of 1 week apart, maybe sessions are 10 days apart. Rarely allow people to come out within like 3 to 4 days after first session, and that's only if they were super healthy and they didn't have any after effect, any after pain. I was the guy who I pride myself with the things I can do with my hands, and I'm not saying the Shockwave is replacing that, but the Shockwave machine has enhanced my hands-on skills, not skills, but the effect of my hands-on work. Why? Because besides the special use of the machine where you remove a calcium deposit or break down scar tissue, there is the generalized effect of muscle relaxation. So you can use it not on pathology. You can use it on a tight structure just to reduce muscle spasticity, muscle tension, and that's particularly important in the spinal muscles where I want to do some sort of manipulation on the spine, but the muscle guarding, the muscle tonus is so high, it's hard for me to get to the joint, to feel the accessory motions. So after a shockwave session, muscle tonus is down. There is hyperemia, which means increased blood flow, which means increased temperatures. So muscle is more pliable, more stretchable, area is looser, and hands-on techniques work better because I have less resistance to fight on the muscle level. So even if you wish, again, I always say the machine does two things. It does the simple use when you can use it on any tight muscle for relaxation, or the special use in pathology where you're trying to remove calcium deposits or treat tendinopathies, try to restart healing process, do tissue remodeling, or turn a chronic inflammation into more acute phase so you can reheal. So looking through the chat here, something in Arabic. Malak, how are you? I don't speak Arabic. Hoping you're saying something nice here with those letters. Anyways, I don't see any questions, so we're gonna wrap it up. There is 5 minutes left, and I will at this point end this chat and this webinar. I mean, I hope it was helpful for you, and I wish you all the best with your equipment if you have it, and I hope it helps your decision making if you didn't have it. Oh, there is one question. In your experience, which one is more effective on the frequency, number, or therapy. I'm not sure if I understand that question. Therapy or invest decreasing. I'm not sure if I understand the question from Bernadette properly. Also for group 1, 2, and 3. So your question is, if you mean from frequency of therapies, it's not so, if you mean like how often they come to you, that's not so important. Like, I mean, once a week is the average. It can be on healthy people a little bit shorter time. On others, it can be once a month, if that's what you mean. Or if you're asking me about the frequency of the machine, as I said, I don't think much of this parameter. Frequency of the machine to me should be a constant in the majority of the cases. The only time I change it is when people are at the very beginning, they're not comfortable with this type of therapy. Then I try left and right. I just try to adjust it to something that they may like. And often in my practice, they like the lower frequency better because the machine kind of works a bit slower, and then kind of relax. People can relax more. If that's your question, I hope I answered it. I'm not sure if I understood it properly, but if there is any other questions, go for it. It was a pleasure to talk to all of you. My name is Rosen again. I work in Canada, in Ontario, close to Toronto, in a city called Kitchener. And we offer a full spectrum of modalities from BTL, not just the Shockwave. They have, you probably know, they have pretty much every modality in the market, from cold lasers to high intensity lasers, lymphatism, hydrotherapy, spinal decompression, all kinds of modalities, hands-free sono. I'm really excited with that one because finally I can attach the ultrasound head to somebody's elbow or wrist and set it on 10 minutes and maybe prepare their exercise program meanwhile, or take care of their file. So Bernadetta, from the group you create, which group faster decrease their pain? For a decrease in pain levels, if you mean that the initial analgesia, it's the same for all the groups, whether it's superficial or deep. The first round of therapy at the minimum intensity, 30-40 seconds later, the sensation on the skin is different, so they don't feel it as painful anymore. So the change in the sensation is on the skin level, so it doesn't really matter which group the patient is in, and that allows you to later on increase the intensity. If Shockwave, you can improve the immunity system. I wouldn't say in general the immunity system, but yes, you can probably restart a healing process, which is immune system response. So in a way, you are teasing that immune system. You're applying a stimulus to a body area where your immune system would be challenged now to give some sort of a response. So if this is what you mean in improving the immune system, you are triggering a immune system response. If I had my elbow issue for 2 years and my immune system kind of forgot about it and stopped healing it, and I want my immune system to kick in and start rehealing this, what the Shockwave does for you, it irritates the area, stimulates, re-inflames it if you wish, which would trigger a new immune system response, a new healing response. So in that sense, yes. Sharif, hands-free sono. That's an ultrasound head that you attach to the patient. You don't need to move the ultrasound by yourself. It's what they did. You can see it on the website of BTL. They made that oval head with, I think they have it with 4 or with 6 ultrasound crystals, and the software moves the crystals, activates them on and off in a pattern where it mimics like the therapist is doing the ultrasound, but you're not even there. You just put it on and you leave, and the machine does that movement for you. It's awesome. It's a time saver. It's a and I'm not sure if you ever guys get a little bit of a ache in your wrist from doing so many ultrasounds a day. If you do 5, 6, 10 ultrasounds a day, we're a busy clinic. We have sometimes like between 3 physiotherapists and 2 massage people, we have like 100 people coming a day through the clinic. We're open 7 to 7, 12-hour operation. We have a lot of treatments, and luckily we have 3 to 4 assistants to where we can delegate some of the treatments, not the Shockwave. The Shockwave is something that I prefer to do myself, but some therapists in Canada can be delegated or assigned to assistants to help you with maybe putting electrodes on the patient or turning machine on or off, or giving them a hot pack or an ice pack, or teaching exercises. Well, all the best. I'm going to exit the webinar now. Thank you for listening, and I hope that was useful for you. Take care.